Good evening, everyone, and welcome to this evening's webinar. In the interest of time, we are going to go ahead and begin the webinar. Welcome this evening. I want to provide a little bit of background information before Dr. Bornstein leads us off. We are in a Zoom webinar, which I know many of you are familiar with. This means that your microphone and cameras are disabled, but we are able to see who's out there in the audience via a participant list, and we would encourage you to submit any questions via the Q&A function or the chat function. We hope to have these questions answered at the end of the session by the presenters. So please submit those questions and the presenters will be checking those periodically. This is a session that is approved for continuing medical education. None of the presenters or speakers have any information to disclose or any relationships with ineligible companies. This is approved for 1.5 hours of AMA PRA Category 1 credit. And following this evening's webinar tomorrow morning at 8 a.m., since this is an evening presentation, you will receive a link to a SurveyMonkey evaluation along with some valuable resources that the speakers will discuss in just a few moments. So please take a moment to complete that evaluation. And from there, once we've received your evaluation, we'll be sending out CME certificates. With that, we will turn things over to Dr. Bornstein.
Thank you. I am going to see about sharing my screen here. Yay. But I just lost my, hang on, there we go. All right, just have to move a couple things around so I can get to it. Thank you, thank you. So welcome everyone, and thank you for joining us tonight. I'm Susan Bornstein, prior GLMS president, longtime supporter of organized medicine and an OBGYN by passion and training. Before we launch into the program, I want to extend my sincerest gratitude to tonight's speakers, with special recognition to Dr. Heidi Koenig, who came up with the idea of presenting this educational seminar, as well as Miranda Mosley of the KMA, who provided exceptional administrative support and guidance. The US healthcare delivery system is incredibly complicated and difficult to navigate for nearly every participant, including patients, providers, insurers, medical suppliers, pharmaceutical manufacturers, and the government. Talking to my colleagues who are incredibly caring and well-educated, I discovered that even they did not fully appreciate all of the challenges to care that were faced by their patients, as well as themselves, nor the deleterious consequences that are a result of our healthcare delivery system structure. We won't be able to cover all of that in an hour and a half. Our goal is to provide you with a high-level overview. If there's interest, we're open to the idea of developing our one or a two-day course to explore these topics in greater detail. I frequently hear politicians say that the US has the best healthcare in the world. Well, does it? We spend nearly 18% of GDP on it, which is the greatest amount by far of any developed country. However, 30 million people are uninsured, and another 29% or 95 million are considered underinsured. And it's estimated that between 22 and 51% of people avoid medical care secondary to cost. People in the US have lower life expectancy, higher suicide rates, more chronic disease, and more obesity compared to similarly economically advantaged countries. We also have unacceptably high maternal and infant mortality rates. In the Commonwealth Fund's 2021 report, and I'm going to provide a link to that in the resources page, which compares the US to 10 other high-income countries, the US not only finished last overall, but finished last in every single metric but one. Within the US, Kentucky's healthcare metrics are the top or the bottom of every list, which are most lists, whichever is worse. And I put a few statistics up for you to see. This is from the recently released Commonwealth Fund's 2022 scorecard on state health systems performance. And I will also provide a link to this in the resources page. As you can see, Kentucky finished 41st overall and was 49th to 51st in multiple metrics, most of which were entirely avoidable. Why is having insurance important? Well, first of all, if you're uninsured, you pay the rack rate or the non-negotiated, non-discounted rate for any and all services you receive. Some medical offices or providers won't see you if you don't have insurance. Medical bills and time off work related to illness are responsible for 2/3 of bankruptcies in the United States. In addition, uninsured people have worse health outcomes, as shown on the slide. Prior to the 2010 passage of the Affordable Care Act, and I was really appalled by this, but 20% of people who applied for insurance on the individual market were declined, as in, sorry, you just don't get health insurance. At that time, 46.5 million people were uninsured. The Affordable Care Act has made this situation significantly better. The number of uninsured dropped to a low of 27 million in 2016, which has risen to around 30 million in 2021, which is the most recent year for which we have data. As I'm sure you're all aware, COVID caused massive disruptions in the workforce with loss of employer-based health insurance benefits. This was fortunately offset by more generous eligibility qualifications and subsidies available for marketplace plans. The Affordable Care Act delivered a number of very important protections for covered lives. One of the most popular is the elimination of pre-existing condition exclusions. I was interested to know that prior to the passage of the Affordable Care Act, a lot of maternity coverage benefits required a special rider on people's insurance. You had to purchase a special rider to get maternity care. So in the ACA, the maternity care coverage is guaranteed, as is woman care and contraception. However, you might also be interested to learn that there's currently a case pending in federal court in Texas challenging the Affordable Care Act's preventive services requirement. The judge, Reed O'Connor, is the same one who, by invalidating the individual mandate in 2018, claimed that therefore the entire ACA was unconstitutional. Fortunately, or at least I think it's fortunate, the US Supreme Court saved the remaining portion of the ACA. But if Judge O'Connor's 2022 ruling is upheld, potentially more than 150 million people will lose guaranteed access to such tests and procedures as mammograms, colonoscopies, and vaccinations. Well, what are some of the drawbacks to the ACA? I talked about some of the good points. What are some of the drawbacks to the ACA? First of all, or things associated with the ACA. The elimination of the individual mandate took younger, healthier people out of the insurance pool, potentially driving up rates. A 2017 executive order by President Trump made it easier for employers to opt out of the contraceptive coverage requirement. There are no incentives for insurance companies to address social determinants of health, which are thought to be responsible for about 80% of health outcomes. Evaluating and choosing health insurance plans remains extremely complicated and time-consuming. And then there's cost. For marketplace plans in 2022, the individual deductible and out-of-pocket maximums are allowed to be as high as $8,700 a year, rising to $17,400 for a family. In Kentucky, the cutoff for Medicaid for an individual is $18,075. So if you don't have an employer-sponsored health insurance plan and you make $19,000, which is over the cutoff for Medicaid, and you buy your insurance on the marketplace, you're at risk of spending more than 50% of your take-home pay on healthcare. There is no question that access to health insurance is better as a result of the ACA. It's just not as good as it could or should be. With respect to terminology in this program, I wanted to offer some clarification on verbiage. There are multiple terms bandied about when we talk about healthcare delivery system reform. However, tonight and in the American political discourse in general, what we are actually talking about are models for healthcare financing. None of the proposals being considered for adoption in the US involve the government employing physicians. Yes, that occurs in the VA system here and in the NHS in the United Kingdom, but those are not part of any of the models listed here, nor being referenced by tonight's speakers unless specifically noted. So that's the end of my presentation. Our first official speaker tonight is Dr. Greg Cooper. I've known him for decades, and I'm thrilled that he agreed to be here. He's a family physician in his 41st year of practice in Cynthiana and Falmouth, Kentucky. He has, throughout his career, been active in organized medicine. He's past president of the KMA and serves on Kentucky's delegation to the AMA. Greg, welcome.
Thank you very much. Appreciate you putting this together, Susan. I'm questioning my first slide. That's not the slide that I'm familiar with. Miranda, can you explain?
Dr. Cooper, this is Miranda. Do you see the slide that says, where would you like to receive your health care?
Yes.
And those are not your slides?
The first slide was a redo of my first slide, apparently.
Okay, Dr. Cooper, it could be that we created a title slide for you just to add in name and information. Does this look like your slide?
You can go back to the first slide. I can.
Okay.
I haven't lost much with your change. So.
Okay.
Okay. So again, I appreciate being here tonight. My task is to present what's good about U.S. healthcare. On my initial slide, I couldn't resist including the Latin phrase "ecce quam bonum." My son is a graduate of Sewanee University of the South, and that's the motto for the University of the South. And see how good. It's from Psalm 133. So my presentation is to see how good the healthcare system can be in the United States and to offer that positive point of view. So Pat Benatar is touring this year, and she dropped her famous "Hit Me With Your Best Shot" song because she thought it was politically incorrect. And I'm not quite as politically correct as Pat Benatar. So if you'd like to go back to the previous slide, my best shot for my presentation is, where would you like to receive your health care? And I want you to think of that as we go through this presentation. You've heard already many of the inadequacies of our healthcare system, and you know personally many of the inadequacies of the healthcare system. But if you are sick, where do you want to receive your health care? I want to receive my health care in the United States of America with the physicians that I'm familiar with and the technologies that I'm familiar with here. Next slide, please. Found this in a little article that was entitled "Pandemic or Not, America has the Best Healthcare in the World." The article actually said when President Trump, but I amended this because President Biden was recently ill with COVID-19. And when the president fell ill, there was absolutely no contemplation of moving America's head of state to another country to receive healthcare services. This might be surprising considering the World Health Organization ranking of our healthcare system at 37th globally. Wouldn't we want our president to be treated in the country with the very best healthcare? Next slide, please. So look at us. The U.S. has the best survival rate for COVID-19 in the world. The U.S. has the world's best cancer survival rates for 5-year survival for 18 of the most common cancers. The U.S. has the best longevity after age 80. If you're after age 80, you want to hang in the United States. The U.S. has better heart attack survival rates than any place else in the world. Post-operative sepsis is less common in the United States because of the system that we have and the cleanliness and the hygiene of our systems. Access to care. Now, this is an interesting point that will be debated, I'm sure, later on. Access to care is better in the U.S. There's several resources that will argue that point. You don't have to wait for months to have your procedure done, as you do in some of the United Kingdom or in Canada. We know that those things happen, and people come across the border. Hundreds of thousands of people come across the border from Canada to the United States to get shorter wait times for their care. Virtually all American hospitals are legally obligated to treat patients in need of emergency care, regardless of their ability to pay. You can come into the emergency room of our hospital here in Harrison County, or any hospital in the state. If you're having a heart attack or you have an emergency medical situation, you're going to get excellent care. America incentivizes and rewards medical innovation. I'm sure this will be discussed too. I am an advocate for capitalism, and America's successes in healthcare, a lot of those are due to the fact that America incentivizes and rewards medical innovation. And we don't want to do anything in trying to change our systems that's going to impede innovation in our healthcare system. And many other countries in the world benefit from what we develop here in the United States. You remember the National Institute of Health study that showed that there were a lot of adverse events in hospitalized patients. Here's a follow-up from JAMA, July 12th, this year, volume 328. In the US between 2010 and 2019, there was a significant decrease in the rates of adverse events in hospitalized patients. Next slide. So here's another little article that talked about 5 things that make the US healthcare system great. Again, rapid access was emphasized. Patient choice and empowerment is emphasized. You get to choose in the United States of America who your doctor is, where you want to be taken care of. So there's a lot more choice and empowerment in our system than in other countries. And if you stay in the hospital, if you come to our hospital at Harrison Memorial, you're going to have a comfortable environment. You're not going to be on a big ward. You're going to have private rooms. You're going to have your own bathrooms. That's not the case everywhere in the world. Our statistics are better for heart attack, for stroke, for cancer, despite what was pointed out in the earlier slides about the problems that we have in the United States with chronic diseases and problematic lifestyles. We have issues here that are more prevalent than in other countries, and yet our healthcare system handles them. Research, innovation, and entrepreneurship, I would hit again as a reason that we are successful on many fronts in the United States in healthcare. Research and development, pharmaceuticals are developed here, procedures are developed here, technology and treatments are available in the United States that are not available elsewhere. Next slide. Just as an example, we'll talk about the pharmaceutical companies. I'm sure they'll get talked about a lot because they make lots of money. But because they make lots of money, they can innovate and develop medications that help your patients in mind. In the top 10 pharmaceutical companies in the world, we have listed Pfizer, AbbVie, Johnson & Johnson is the top 3. Then we have Novartis from Switzerland, Roche from Switzerland, Bristol Myers Squibb USA is the 5th one. Merck is also USA company. AstraZeneca, United Kingdom, Sanofi, France, GlaxoSmithKline is the UK. I know this is a little deceptive because actually a lot of these countries, no matter where companies, no matter where they're headquartered, they're actually multinational, and we all know that that's true. But my point is that the United States is a great environment for allowing these companies to innovate and develop medications that save our patients. Next. Lawrence Vanderbroek, who's the CEO of Chronolife in Paris, a digital healthcare company, makes the point that when it comes to preventative care, the United States currently outshines many European health systems. We have a hybrid system that ensures better access to preventative services, and we can talk a lot tonight about preventative care. Preventative care is an area where the U.S. system shines thanks to a combination of insurer-driven efficiencies and government-led investments. Different perspective than from inside the United States. So, sometimes the grass is greener, and it's good to have a perspective from someone across the pond. Next. I think that concludes my presentation. The last 2 slides are the resources and references, and I thank you for.
Thank you, Dr. Cooper. We may be having a little bit of an issue with your connection. Dr. Bornstein, I'll hand it back over to you to introduce your next speaker. Dr. Bornstein, you're muted.
That's my penalty for being good and remembering to mute myself, but not to unmute myself. So Dr. Koenig is a wife, mom, and lover of gardening. She's the professor and vice chair of anesthesia at the University of Louisville, where she teaches and cares for patients day to day, as well as at the VA. She serves on the Kentucky Board of Medical Licensure. She's editor-in-chief of the Journal for Medical Regulation for the Federation of State Medical Boards, and frequently raises awareness of politicians in Frankfurt and in Washington, D.C. Welcome, Heidi.
Thank you, Dr. Bornstein. How access to care is impacted by our system's structure. Access is everything. I just got back from Mongolia, and I think they have universal coverage, but nobody can get to it. So our access problem isn't as big as theirs. Next slide, please. So part of our challenges in this country are provider distribution. You know, if you're in downtown Chicago on Michigan Avenue, there are great towers just jam-packed with dentists and doctors and surgeons. But if you're out in the rural bits, you may have to walk a ways to get care. Or drive on terrible roads. If you're in poverty-stricken areas, the physicians aren't in those locations. Next slide, please. Sometimes even if you're in close proximity, there are biases that might prevent you from seeking care. Maybe you have a substance use disorder, gender identity that might be criticized or shunned, racial, ethnic, cultural differences. Geography, again, is huge. You're afraid of the cost. You may be low income, underinsured, uninsured. There may be language barriers, cultural barriers. Pregnant women often have little children to take care of. They don't have anybody else to take care of them unless you have good grandmas like Dr. Casper. So, you know, there are just lots of barriers to actually physically taking time off from work to go to care. But like I said, we still have much better access than people in third world countries. Next slide, please. So who goes to the underserved areas? American medical graduates with high medical school debt often can get some debt relief if they are willing to serve for a number of years in a rural area or in an area of poverty where maybe it's a little harder to practice. International medical graduates who want citizenship often end up in remote areas to achieve a visa waiver. And these combinations of international medical graduates in rural areas often are very difficult because the language barriers, the cultural barriers, it's very difficult for both the American medical grads who don't understand the context of their patients' lives and the internationals. So we strive for culturally and linguistically appropriate services and overall more relational, respectful, culturally competent services. And that you just have to immerse in the culture of the community you're serving in order to achieve that. Ideally, you'd have in-person professional interpreters to increase effective communication. And then the final leap that is often difficult, post-visit summaries in the patient's own language. And I saw some of this going on with Google Translate recently in a pre-op clinic visit. And I thought, I hope Google understands what we're trying to tell this patient. And yeah, we didn't have an interpreter for that language. And so she's coming for surgery tomorrow. We'll see how it goes. Next slide, please. So rural health, there's a lack of primary care specialists. Hospitals are closing. There are pharmacy deserts. In 2020, the Kentucky Hospital Association reported 28 of 69 rural hospitals were at risk of closing, and at least 5 actually have closed since 2005. And I haven't gotten more recent data. I want to say there have been a couple more that have consolidated or completely closed with healthcare systems. This problem of rural hospital closure is most desperate in Texas, Tennessee, and North Carolina. Next slide, please. And this is just the information I have access to. You can see the major population areas, the Louisville, Lexington, and Northern Kentucky area. The blue triangles are nurse anesthetists or advanced practice nurses, and the purple dots are physicians. I think when they went to more liberal independent practice guidelines for advanced practice nurses in Kentucky, they thought this would facilitate better distribution of those providers. But I would venture to say physicians and advanced practice nurses want to stay in metropolitan areas, more affluent areas, and that other specialties probably have a very similar distribution. I think there are only 2 counties without physician at all in Kentucky, but I again don't have that data. There's a question, what's the red dot? I am not sure. I got this from our lobbyists in Frankfurt. The red dot may just be a mistake. Next slide, please. So again, back to our ethnic, racial, gender inequality, low income, language barriers, and substance use disorders, all these barriers. And recently, the GLMS News had a piece about access to care, for really highlighting OB care and prenatal care, Black immigrant refugee patients. For many of them, if they're new to the city or the country, they don't know where to go for care. Navigating a new city, especially if they have other children in tow, language barriers. And I just love that first slide Dr. Bornstein put up of the maze that you have to go through to get to where you need to be in the complex healthcare system. The cost of care, when you don't negotiate, you just get the shelf price. Insurance coverage is prohibitive for many of these individuals who often are underemployed or unemployed. Medical racism, especially related to pain management. There are a number of dissertations on lower lower levels of narcotic administration, lower incidences of pain prescriptions for African Americans and Latinos. Next slide, please. And I'm at my time here. Can we get the next slide, please? So there are a couple resources. One of the biggest things is trust. This again from the GLMS News. AMA's 7 Keys to Health Equity, and the Department of Health and Human Services Think Cultural Health, that I'll point you to for further education and to kind of dissipate the differences in access and interactions with patients of different ethnicities and other biases that potentially come up between providers and patients. And I thank you very much. And we'll just, yeah, I can go on and on.
Thank you, Heidi. Can you all hear me?
Yes.
Okay. So next up is Dr. Gene Shively. He is, and thank you for your wonderful presentation, by the way. Sorry, I was so focused on my next task. Dr. Shively is a retired general surgeon from Campbellsville, Kentucky. He has been doing a podcast on the U.S. Health with Dr. Mike Flynn for about 1.5 years and is mastering a lot of new technology in his leisure years. Welcome, Dr. Shively.
Thank you. Can you hear me?
Dr. Shively, this is Miranda. You'll have to mute one of your devices.
Okay. Can you hear me now?
We can. We're getting a little bit of background reverb there. There you go. Can you speak now?
Yes.
Okay, that's perfect. Thank you. You're ready to go. And just as a reminder, you'll just need to let us know when you're ready to advance your slide.
Okay. Well, I got interested in the excess cost of medicine several years ago, and I started looking into it. I want to give a disclaimer that a lot of this data is not rocket science. It's and it's not reliable, but it's probably the best you can get from the literature. For example, one of the things that I have described is defensive medicine, and of course, everybody's going to agree or disagree about the different patients with defensive medicine. Next slide, please. We spend about $4.1 trillion in healthcare. There's different estimates of what that is to the GNP. Barbara had 18%. I came up with a number of 19.7%. It's projected that in 2027, it will be 22%. That represents the 5th largest economy in the entire world. And just for a comparison, the Department of Defense spends $778 billion. So if we could cut approximately $1 trillion from our healthcare costs, it's estimated the United States could compete with the rest of the world. Next slide. Currently, the U.S. is considered the 10th most unhealthy country in the developed world. The U.S. spends twice as much on medical care as 10 other high-income countries. Next slide, please. The 3 biggest costs affecting U.S. medical care is for-profit insurance. As you know, We hold a monopoly on for-profit insurance. Most countries do not even have that. Pharmaceutical cost and administrative cost. Next slide, please. It's estimated that for-profit health insurance company collect a total of $23 billion, and that was in 2020. The profits actually increased during COVID, and that was because elective procedures were radically cut because of the COVID. But do you think those insurance companies turn that profit back to the patients or decrease premiums? Next slide, please. Pharmaceuticals is a big problem in America. The pharmaceutical market in the United States comprises almost half of the global revenue. Saying that another way, about a half of all the pharmaceuticals bought in the world are in the United States. The per capita spending on prescription drugs is estimated to be about $1,300 in 2021. That number is going up. The per capita healthcare spending on pharmaceuticals in the US is almost double that of Canada. Pharmaceutical companies, until just the last few days, have changed, can charge indiscriminately for Medicare Part D drugs. And I don't know the details of the new law, but I understand it's going to be a few years before that goes into effect, and it's only going to affect several drugs. One of the biggest problems in a pharmaceutical industry is the benefit managers. The pharmacy benefit managers play a large role in manipulating prices. They negotiate with the drug companies, and then they negotiate with pharmacies. For example, they may have one negotiation with Kroger, another one with CVS, and another one with Walgreens. That's why you may go to one drugstore and the drug is one price, and go to another one, it's a different price. There are some situations where you can pay cash and you can get your drug cheaper than if you use your insurance. Pharmacy benefit managers are a big problem. They can probably be eliminated and save a huge amount of money by directly buying from the drug companies, and then the retail pharmacists selling them to the patient. Next slide, please. U.S. spends approximately 3 times on administrative costs as most other countries. The approximate cost is $812 billion. It's estimated that we could save an average of $158 billion. Now you got to remember that the number of administrators in hospitals and offices has dramatically increased. Since 1970, it's almost gone up at an exponential rate. The number of physicians has only gradually increased since the 70s. Most of the reason for that is dealing with different insurance companies and also with regulations from CMS. Next slide, please. Other healthcare expenditures include advertising. U.S. healthcare industry spends approximately $30 billion on marketing. We're the only country in the world that allows professionals, doctors, lawyers, hospitals, and pharmaceuticals to market, except New Zealand, which allows pharmaceuticals to advertise. Now, these numbers do not include sales representatives or marketing research. Next slide, please. These estimates do not include other health expenditures. For example, EMS. Most people don't realize that if you get transported from Campbellsville to Louisville or Lexington, the bill can be $50,000. Now, fortunately, most of the insurance companies pay a part of that or most of it, but if you don't have insurance, you're in big trouble. nursing homes. I hope that most of you know that 70% of nursing homes are owned by equity companies, and that's only happened recently, and most people don't even know that. For example, in Campbellsville, Greene County, Adair County, and Casey County, all the nursing homes are owned by equity companies, and most of us did not know it. I only found out about a year ago. How do you make money on nursing homes? Well, you decrease your nursing and other personnel. This is a huge problem, and will eventually have to be addressed. As you know, most equity companies expect a big profit. They usually expect from 10 to 20% over 5 years. Other costs that I have not looked into is rehabilitation, dental care. Dental care is almost impossible for those below the poverty line. Most people do not have dental insurance, and the same way is with vision care. Home health and durable and non-durable equipment, I don't know the cost of. Next page. Now, this is a slide that just grossly shows the potential savings in American medicine. Now, obviously, some of these numbers are a matter of opinion. For example, unnecessary ER visits, unnecessary hospitalizations, and I'm sure the for-profit hospitals would argue that that they're providing a service to the community because they pay taxes. Next paragraph, next slide, please. Well, I've estimated, and this is a gross estimate, that just by decreasing these excess costs, that we could save $1.354 trillion. This might be enough money that we could provide care for everyone, and that we could have universal health care, and we might not even have to raise taxes. Next slide. Thank you very much. If anybody has any questions, I'll try to answer them in the chat room, or you can email me at eugeneshoffley@gmail.com. Thank you.
Jean, thank you for an excellent presentation. Our next speaker is Dr. Barbara Casper. We are particularly thrilled that she's able to join us tonight, since she is having special brand new grandmothering duties, and she's carved some time out of her evening for us. She completed medical school and residency in internal medicine in Tennessee. She spent 12 years on the faculty in Tennessee prior to joining the faculty at the University of Louisville, where she was the program director for the internal medicine training program and chief of the Division of General Internal Medicine. She spent her career caring for the uninsured and underinsured patients and has developed a passion for health equity. Welcome, Barbara.
Dr. Casper, you're muted.
Sorry. Again, I thank you for having me, and I'd like to focus my portion of this talk about the costs of insurance and taking care of patients. So first slide. So I think at least I took care of a lot of Medicare and Medicaid patients, and I honestly don't think I understood the cost of Medicare to my patients until I actually had Medicare. And so I wanted to just go over a little bit about the eligibility. Everyone over 65, people who are under 65 who are permanently disabled for 2 years, and those people that have a diagnosis of end-stage renal disease or ALS. There is no cost to the recipient. Everyone has to sign up for it. It is funded 90% by payroll taxes. But it does not pay for all services for patients. So if patients only have Medicare and no supplement, they pay, there's a $233 deductible, and then Medicare will pay for 80% of a hospital stay. So you can see that the remaining 20%, particularly as the cost of hospitalizations are significant, could be really devastating to a senior. Next slide. Then Medicare B has the same eligibility as Medicare A, but it is only optional. So people have to opt in, and the monthly premium averages about $170 per month. So again, for lower income people, they may not be able to access this. This particular portion, as many of you know, covers the physician visits, the outpatient services and preventive care, and some home health. But again, it only pays for 80% of physician fees and services. So the patient will be billed for 20% of that cost. Next slide. Many people opt to get, in order to address this, a Medicare supplement or what is called a Medigap an insurance policy. This is usually through a private market. Many insurance companies have these, and the average monthly premium is $143 and change at the age of 65 and goes up to $235 at the age of 85. So what this pays for is majority of what Medicare does not pay for after a deductible. So again, can be prohibitively expensive for those patients who are at the lower end of the socioeconomic strata. Next slide. And then there's Medicare D, and many of you are familiar with this. Enrollees must sign up for it within 63 days of starting traditional Medicare. If they do not, at some point when they do enlist in it, they actually are charged a premium, a penalty for the remainder of their time on Medicare, and that's $33 per month. Now, some of this will change based on the new law. And so, but previously it was the premiums are income-based and have a maximum deductible per year of $488. And once deductible is reached, plans pay for prescriptions and recipients will pay a copay depending on the plan. It previously, once the insurer and the recipients reached the payment in the amount of $4,450, which is a significant amount of money, patients entered the donut hole, which can be devastating for patients who are on very expensive medicines. And then they pay for more cost of the drug until they actually reach the cost of $7,050 per year. In the new law, the maximum amount that a person would pay per year is $2,000. And my understanding was that this was actually going to go into effect at the first of the year, but I'm not quite sure about that. Next slide. And then there are Medicare Advantage plans, and this is where CMS pays insurance companies to administer the plans. And this essentially privatizes Medicare. So you probably have seen a lot of the kind of the B celebrities, Joe Namath and Jimmy Walker, advertising these, and they offer a lot of services which can be appealing to patients. The downside of this is that they have a limited network of physicians. So unlike Medicare, where you can travel and you're covered wherever you are, and also you can choose your own physician, you may not have that ability. And then there are many procedures, et cetera, that require prior authorization, as do all insurance companies for things. So there are some disadvantages to patients for this. And if they end up being sick, they can actually be charged more and eventually not be able to afford it. And in which case, if they opt to go back to traditional Medicare, they may have difficulty actually finding a Medigap program. Interestingly enough, the federal government spent $7 billion more on Medicare Advantage plans than traditional Medicare in 2019. So it is not cost effective to the Medicare program. And it actually has a lot of pitfalls for the patients. Next slide. Then we run into employer-based insurance, and this is all over the map as to what percentage of the bills that the programs pay for. Usually it's an 80-20. The plan will pay for 80% and the recipient 20% or 70-30. It has an out-of-pocket maximum per year, and some of them have very high deductibles, which allow the patients to pay lower premiums, but it can be very expensive. And insurance premiums have increased over 50% over the last decade, and now on average, through the employer-based insurance, about $21,000 for family coverage, and the employee costs are about $6,000 on average. Next slide. Medicaid was expanded under the ACA, or was allowed to be expanded. It traditionally covered children, elderly, and pregnant women who were impoverished. But it does allow expansion to all folks who meet criteria. And Susan mentioned 18,000 per year. The information I got was 13,000 per year for a single person, with 27,750 per year for a family of 4. Very difficult to live on that amount of money. 39 states did expand Medicaid. That included Kentucky and DC. And interestingly enough, when Heidi mentioned some of the problems with physician coverage in rural areas, a lot of the states that he mentioned did not expand Medicaid. So those included Texas and Tennessee. So Medicaid pays for hospitalization, outpatient treatments, and medicines. Next slide. And then the VA is the only example of socialized medicine in the United States. This is where the physicians are employed by the Veterans Administration, and all the medications and care is provided there. Next slide. Dr. Shively mentioned pharmacy benefit managers, and there are 3 major PBMs in the United States: CVS Caremark, Cigna, and United Health Group. And these are basically a third-party administrator of prescription drug programs. Next slide. So they negotiate drug prices with the pharmaceutical companies, and then the patient fills the medication and often has a copay. So the pharmacy benefit manager then reimburses the pharmacy a portion and is able to pocket any of the remainder that could include a rebate from the pharmaceutical company. So patients often don't know the cost of the drugs, which actually may be lower than what they are charged through insurance. And previously there was a gag order which forbade pharmacists from informing patients of that. But in 2018, a law now allows a pharmacist to inform a patient of the lowest cost. So for example, it may cost less to actually purchase the drug with cash than to run it through your insurance company. Next slide. So how does this translate into what patients experience? And so about 2/3 of all personal bankruptcies are precipitated by medical costs in the United States. And 60% of adults in the US actually have medical debt at some point in their lives. 70% of people will cut their food expenses to avoid bankruptcies. And one key thing to keep in mind is that 62% of people who have medical debt were insured at the beginning of treatment. So I've already gone through kind of the gaps in payment that patients have even with insurance. Most patients with medical debt have no other debt. So these aren't people who just live on credit cards. They just have had a catastrophic illness. And 39% of patients with medical debt have employer insurance. So people say they love their employer-based insurance until they have to use it for something that's really significant. And the average age for medical bankruptcy is 44.9 years. So these are people in the prime of their lives and having families. Next slide. Most people who have medical bankruptcies are insured. And so then there are those people that are uninsured, and 8.6% of the US population is uninsured. These are largely undocumented residents, impoverished people who live in states who did not extend Medicaid, or those people who make too much to qualify for Medicaid but can't afford insurance through the exchanges we listed before. Next slide. So how would a tax-funded financing system cover everyone, fix these issues? First of all, everyone would qualify regardless of employment, income, et cetera. They would receive a health card at birth. The overhead of administering the program would be decreased. The current overhead for private insurance is listed, and the cost for Medicare is significantly lower, and it would allow people to be flexible in their employment. So for example, people could leave and start new businesses because they would not have to rely on employer-based insurance. Next slide. So the advantages, again, it takes the employer out of the healthcare business. Many businesses would prefer not to be involved in this and would prefer to pay a tax and allow someone else to take care of this. It would decrease prior authorizations. Physicians would be paid more quickly. It would decrease billing staff. There are currently as many billing staff as there are hospital beds in the United States. And this is to deal with the complexity of all the insurance companies. And it would decrease spending as listed there. Next slide. It also allows for appropriate budgeting. There would be no surprises. So people would know that they're paying, I don't know, a tax of $100, $200 a month to cover their medical costs. And if they had a catastrophic illness, they wouldn't be out of pocket that extra money. And it would allow for improved quality assessment of treatments because we would be able to view what the treatments were across the board. Next slide. So it works. It's not socialized medicine. It's a payment method. Both employers and employees would pay a payroll tax similar to Social Security and Medicare now. And the cost to employees would actually be lower than the current healthcare costs in employer-based health insurance, because I've already talked about what the premiums are for people, as well as they're having to pay co-pays. And physician impact would not, incomes would not be impacted. If you look at Canada, physician incomes are actually higher for all specialties except with the exception of dermatology. And I believe that's the end of my presentation. Thank you so much. This is just a summary. Thanks.
Thank you, Barb. That is great. I really appreciate the information you provided. And thank you for being here. And we hope that you'll be able to stay on. We understand you may have to return to childcare duties. Our next speaker is Don Neal. He practiced solo pediatrics in Owensboro for 45 years, then moved to South Florida, where he worked as a float pediatrician for Pediatric Associates for 7 years, returning the last 3 summers to work in Louisville as a float pediatrician for Norton's Children's Group. He is still working from home in Owensboro, reviewing nurse practitioner charts for the group in Florida. Welcome, Don. Happy to have you.
Thank you. Can you see me and hear me?
Yes, we can.
Okay,
Yes,
very good. I'm happy to be here this evening. Especially, I thank Dr. Cooper for his notation that if you live in the USA, you have a good chance to living to more than 80 years. Since I identify with that, I appreciate that very much. Although it was challenged a bit, we went to Memphis this weekend to the FedEx golf tournament, had a great time, stayed with our daughter, but didn't realize she was incubating COVID. So on Sunday when we got home, we both had a bit of fever and cough, and needless to say, we both tested positive for COVID. So if I cough a little during this, please forgive me. My job is to talk a little bit about physician-patient frustrations. And of course, you can just barely do that in about 9 minutes. In my view, I will say that this started in the 1980s in particular with our frustrations, when the cost of healthcare was escalating, and it was decided the powers that be that we needed to manage healthcare. Now, actually, I believe what happened is that big business and insurance companies realized that there were big profits to be made in medicine, and they wanted their share. So enough to be said about that. Therefore, however, when the managed care train left the station, physicians were passengers and were not engineers or conductors. And it's been downhill ever since, as far as I'm concerned. We physicians were too busy seeing patients to really lead the way to the development of managed care, in my opinion, also. And what followed was contracting, networks, co-pays, not to even mention prior authorizations, forming groups, hiring managers, and trying to survive. As practices grew, the need for more help grew, and because physicians, particularly in primary care, were a bit hard to find, we turned to mid-level practitioners. So entered the nurse practitioner and the PA. Now, I guess we could say that a lot of that started in Kentucky with Frontier Nursing Service in the 1800s, who ensured that as best they could, babies in the mountains were born healthy and children got a good chance to grow up healthy. The birth of the nurse practitioner actually was in Colorado in the 1960s. And I was fortunate enough to be there in training at the time. And one of my mentors, Dr. Henry Silver, was one of the ones who developed the idea of the nurse practitioner for the mountains of Colorado. They performed quite well, and they have spread gradually over the country, and now we have more than 200,000 nurse practitioners and PAs. The frustration that comes at this time has been their collective desire to gain independent practice rather than being a part of a physician-led team. And where that has become complicated is that state legislatures have determined that this is a turf battle and not really a quality of care issue. And we would debate that, because we can tell you that with the training that nurse practitioners have, they need to be under the tutelage of physicians, physician leaders for at least a period of time. In fact, my job at the present time of the company that I work for, which is a private pediatric group, is we review the nurse practitioner charts for quality, for referrals. We have them on speed dial, and with any issues, we're there to not only look over their shoulder, but have their back. And I can tell you that it works quite well. I don't know if anybody else in the country is doing that. I think that this will become a larger problem as the number of primary care physicians dwindles. It is estimated there will be a shortage of about 120,000 primary care physicians in the next 10 years. So I think this is something that needs to be looked at. I think that patients are concerned. They have a doctor, but is their doctor a physician? And I think that is something we need to think about. Now, all of that pales to the effect of the innovation of the electronic health record and EMR to primary care practice. The promise of upcoding, more income, efficiency, less legal liability, and higher quality care has been largely unrealized. One can argue that the EMR has given us a tremendous amount of data. And in fact, we're almost budging with data at this point. But that comes at a big price for the primary care physician in financial investment and in the problems of decrease in numbers of patients that can be seen, increase in administrative time for MDs has gone from 3 or 4% to 15 to 18%. And also, this also ties into less patient satisfaction. In fact, I hear patients constantly saying, "Doctor, are you treating the computer or are you treating me?" Somehow, as we get through whatever healthcare is going to evolve into, we've got to figure out a way, because dragon dictating scribes has only been a partial salvation there. So we'll see what happens. Now, add this to the fact that primary care reimbursement and compensation has not kept up with the increased practice cost, and the majority of practices have begun to sell out to hospitals, corporations. I would say at least 3/4 of the primary care doctors that come out of training now are working for someone, maybe a group, but mostly for a hospital or corporation. We are also to the point where we're not really filling all of the residency programs in primary care. And I think that's going to be a problem for the future. So bottom line is that doctors are unhappy. Some have become concierge doctors or have gone into direct primary care to increase income while having a smaller panel of patients. While that's good for that small panel, that leaves the other 75% of the patients they were caring for to find other care. And so access to care is becoming a problem in most communities, especially small communities, I think. The movement to replace fee for service, which seems to have become a dirty word, with value-based care, and has been a non-starter in pediatrics, and I think it will likely fail for primary care, as evidenced by the failure of the ACOs to save money and increase quality for Medicare. They are now starting to work with about 8 states, I think, to work on some sort of other payment method, such as a per member per month, as we had under Kenback in Kentucky years ago. The idea of having physicians accept risk based on outcomes cannot succeed, as far as I'm concerned, with the present methods of reimbursement, and it will be interesting to see how that bears out. I've just scratched the surface in this period of time on this, and I look forward to any questions or comments. I'll leave you just with this. Don Berwick has recently been quoted, who's a futurist, And I think Susan and some others mentioned a bit of this, that we're approaching 20% of gross national product for payment of healthcare. But what was pointed out is that what we physicians do only manages about 10% of health. The other 50% or the other 90%, 50% is genetics, and the other 40% is based on where you live and how you live. So that will be interesting to see how that plays out as we come to a new system. Thank you very much. I appreciate your attention.
Thank you, Don. I know you spoke for a lot of physicians with your heartfelt comments. Next up is Dr. Jane Katz-Field, who is kind enough to join us from Vermont. She's a pediatrician who retired from practice in Brattleboro and previously worked in a hospital-based practice in Camden, New Jersey. She led the successful effort in 2020 to get the Vermont Medical Society to endorse a resolution in support of a single-payer national health program, and Vermont was the first state to do this. Welcome, Dr. Katz-Field. We're really happy to have you.
Thanks so much. I'd like to address some of the concerns I've heard from physicians when the topic of universal access and tax-funded financing comes up. Next slide, please. Many doctors are concerned that such reform might decrease their income. While physicians are highly paid, these concerns are understandable given the burden of student debt, the length of medical training, and Medicare's lower fees relative to private insurers. But are such concerns supported by evidence? Let's first look at the gross income of physicians in 2019, both in Canada, which has a tax-funded healthcare system, and in the US. Next slide, please. Family medicine physicians in the US grossed an average of $231,000 compared to $280,000 in Canada. Medical specialists, $341,000 compared to $363,000 in Canada. And orthopedists, $482,000 compared to $438,000 in Canada. Next slide, please. If alternative payments like capitation are included along with fee-for-service payments, Canadian family physicians' gross payments were $327,000, medical specialists $400,000, and surgical specialists $568,000. I couldn't find a figure for the average surgical specialists in the US. Another way of looking at physician payments is examining calculations by the Nonpartisan Congressional Budget Office, which recently estimated payments to physicians in 2030 under current policies, as well as under 5 options for Medicare for all. Next slide, please. The CBO projects that in 2030, providers' total outpatient revenues would be between 5% and 9% higher under Medicare for all. If, as studies suggest, Medicare for all would free up roughly 5% of doctors' work hours currently spent on billing, allowing them to increase patient care, per physician revenue could rise by between $39,000 to $157,000 annually. Although primary care doctors would get the biggest income boosts under a tax-based system, specialists would continue to be high earners. In Canada, as we saw, the specialist to primary care income ratio has remained quite high. These salary numbers do not take into account the greater overhead expenses that US physicians have, which lowers their net income compared to physicians in Canada. Next slide, please. In 2019, 45% of US physicians' income was net income and 55% went to overhead. The other part of that slide, please. In Canada, 72% of their income was net and 28% went to overhead. Let's look at some of the expenses that US physicians have. Next slide, please. Physician practices spend an average of $83,000 per year per physician on claims, coverage, and billing, 4 times as much as in Canada. US physicians must pay for claims submission, often to multiple insurers for patients with dual coverage, for resubmission of denied claims, and for responding to prior to prior auth requests, requests to justify non-formulary drugs, and letters from care managers. And this additional paperwork comes with an additional need for administrators, all of which increases overhead. Secondly, Canadian medical students graduate with a median of $80,000 in debt. Over 3/4 of US medical students graduate with debt, the median in 2018 being $200,000. Then there's the cost of malpractice insurance, which takes a big bite out of US doctors' incomes. Future medical costs are a large part of malpractice settlements, but are removed from the settlement equation under a tax-funded system. Canadian doctors are protected by the Canadian Medical Protective Association, a nonprofit organization that indemnifies its members against damages and legal fees. In summary, a universal tax-funded financing system works by cutting waste to the tune of $504 billion a year in administrative costs, not by cutting physician incomes. PCPs stand to see a pay increase, while highly paid specialists might see a slight pay cut, but painful sacrifices would not be required. Legislation around a new universal system must be well designed so Medicare's burdensome payment and monitoring don't persist. Doctors could be paid based on a simple fee schedule negotiated by medical associations. There are always pressures to reduce funding for public systems, and medical associations will have an important role in ensuring that physician reimbursement is adequate. Next slide, please. Will a universal system reduce innovation? There is no evidence that this would occur. Many innovations have been developed in countries with predominantly tax-funded systems. For example, several European countries are way ahead of us when it comes to establishing a useful EMR. Next slide, please. While the US insurance system has a relentless focus on short-term goals, a tax-based system has an incentive to prioritize innovations with long-term benefits. Redirection of funds from paper shuffling back to patient care and publicly funded research and development would enhance rather than impede medical innovation. Next slide, please. Some doctors worry about the loss of autonomy, but most physicians complain about their lack of autonomy under the current system. Next slide. As the insurance industry has expanded, a majority of physicians have become employees of major health systems and hospitals with fixed salaries. In contrast, in Canada, most physicians are in private practice. Because of insurers' mandates, doctors' notes in the EMR are 4 times longer in the US than they are in other countries, even when foreign doctors use the same software. We are obligated to get prior auths for medically indicated procedures, and non-clinical middle managers issue directives. 3/4 of US doctors spend 10 to 20 hours a week on billing and administration. That's time that undermines our autonomy. Under a tax-funded system, patients would regain free choice of doctor and hospital, and doctors would regain autonomy over patient care, control over their time, and experience less demoralization. Next slide, please. Quality of care. Despite spending over twice the per capita average of other economically developed nations, the US lags behind 11 economically developed countries in most quality of care measures. Next slide, please. Life expectancy in the US has fallen since 2014 to its present level of 77, which you see in the mid-right part of the graph. Which I had a pointer, and 70 for a Black male in the US, which is at the lower right corner, at an annual cost of over $10,000 per capita. Life expectancy in other countries is around 82 to 84 at an annual cost of $3,000 to $6,000 per capita. Next slide, please. The US is last on all domains of performance except care process. And you can see at the right of the slide, it's number 11, except in care process, which it does quite well in. Next slide, please. This slide is just a visual and shows the extent to which the US is an outlier. Next slide, please. Drug prices in the US are twice those in Europe and increasing. Lack of access leads to 100 deaths a day. 41% of people under 65 have medical debt, and we lack sufficient primary care physicians and behavioral health providers, especially in rural areas. The COVID pandemic laid bare the dysfunction of our system. In countries with a universal system, unlike what happened here, hospital budgets were not imperiled and not one citizen lost their health coverage. Any concerns about quality of care are answered by the superior outcomes in systems that provide universal coverage. In fact, a recent Stanford study found that veterans treated at VA hospitals, the largest public health delivery system in the US, had survival rates at least 20% better than vets treated in non-VA hospitals. A tax-funded system would let us leverage healthcare dollars to respond to public health crises. Next slide, please. Some physicians say that moving to a tax-based system is just too disruptive, too unrealistic. But consider that Medicare was up and running 11 months after Congress passed that bill in 1965, despite doomsday scenarios. Momentous healthcare change has in fact succeeded despite the relentless messaging that it was impossible. Next slide, please. Messaging from insurance and big pharma stokes fears. They claim their profits are somehow less destructive than a transition to a different kind of financing system. The barriers to a tax-funded system are political, not economic. Finally, some have a distrust of the government, a fear of its intrusion into the physician-patient relationship. But it is private insurers, not Medicare, that burden US physicians with tedious and opaque intrusions into everyday practices. A new system would preserve our present vigorous competitive mix of private and public healthcare delivery with a streamlined, rational, and accountable tax-funded system. Fear of healthcare rationing is a scare tactic that has been used to oppose universal healthcare ever since Truman proposed it in the 1940s. In actuality, the US has long been rationing healthcare based on ability to pay, with severe and unconscionable harm to the poor and to people of color. Next slide, please. As Wendell Potter, former vice president of Cigna and now a whistleblower against the health insurance industry, said, "Our industry PR and lobbying group supplied my colleagues and me with cherry-picked data and anecdotes to make people think Canadians wait endlessly for their care. It's a lie, and I'll always regret the disservice I did to folks on both sides of the border." Thank you.
Jane, thank you for some amazing data. I just have one quick question that might have occurred to other people. When you presented the data on the financial data on the US versus Canadian incomes, were those in America? Were those both in American dollars?
No, the Canadian salaries were in Canadian dollars, and I put it very small at the bottom that in 2019, the Canadian dollar was 75 cents in US dollars. However, if one lives in Canada, everything is relative. So I felt it was fair to look at them side by side.
Thank you very much for the clarification and excellent presentation. Our next speaker is Kevin Pierce. He's a licensed Kentucky physician and professor emeritus at the University of Kentucky College of Medicine. He's practiced as a board certified family physician since 1986. His experiences underpin his interest in our society achieving equitable, affordable, and accessible high quality medical care for everyone. Welcome, Kevin.
Thank you, Dr. Bornstein. Thank you, everybody, for hanging in there with us as we're getting towards the end here. I want to acknowledge my co-presenters aren't speaking because we don't have time for them to do that. Dr. Cunningham is a psychologist and professor at U of L. And Jeffrey Zachem is a education technology expert and also a huge leader in trying to improve equity in care and community health. Dr. Cunningham did a lot of the statistical analyses that I'm going to sample, and Dr. Zachem, Jeff Zachem actually put our survey together into SurveyMonkey, pulled down the data and made all the graphics I'm going to show you. So with that, next slide, please. What is this survey? Hopefully many of you took it. A group developed it, including physicians and researchers, for this very webinar. You got the chance to take it when you saw the registration. If you haven't taken it, you'll get another chance. And I hope that this little bit of taste of what we found will get you to want to see the whole survey, participate in it, and we're going to work to get more complete results out to everybody. This is just a taste to whet your appetite. We had 61 respondent physicians from 24 Kentucky counties. That and other factors will show you that this is not a statistically representative sample of Kentucky physicians. That said, some of the statistics I'll show you are valid just by the fact there's a lot of variability in responses. Next slide, please. So this is the snapshot of things I want to show you, some demographics, some rates of agreement with some of the frequently debated aspects of U.S. healthcare spending and delivery, et cetera. A lot of them you'll recognize as a topic from Dr. Catsfield's presentation a few minutes ago. And then there's some interesting correlates of who would tend to favor tax-based universal health insurance system over the status quo. Throughout, when we say tax-based universal health insurance, we do mean insurance. We do not mean employed providers. And this is explained in the survey. And we mean a scenario in which anyone could purchase supplementary private insurance on top of whatever was tax-based universal. Next slide. So here are some basic demographics. It won't take you long to realize if whether or not this is really reflective of current physician practices. If you've looked at these kind of demographics lately, you can't get a lot of this easily, but one thing you can get is actually the retired physician bar might be close to what Kentucky is. The employed versus partner associate, I actually think partner associate may be a little bit lower in reality compared to employed. Next slide. How many hours do people spend on administrative tasks? I don't know if this reflects reality across most physicians in Kentucky. It kind of rings true to me. Certainly, we're not seeing that the majority are going, oh, I don't have much of that. And this doesn't include charting. So all the pajama time that so many physicians have just completing their charts isn't even on this. This is the other administrative stuff. Next slide, please. Now, this indeed is not representative of the state. This you can look up, and I did. Democrat and Republican registered voters in Kentucky are they're very close to equal now. Independents are only about 1/10 of Republicans and Democrats. So these are our survey respondents. Respondents do not reflect Kentucky physicians politically. And I'll come back to that in a minute. Next slide, please. So among these people that have the demographics I've shown you, and I'm sorry I'm not showing you more, I just don't have time. We have age and gender and all. There's a preponderance of support for moving away from where we are to a different kind of system where there's more universal insurance, where healthcare expenditures are lower, where we have better outcomes, meaning there's need for improvement. I'll say, though, a good minority felt that there's a risk of the system being too burdened by too many people demanding access to healthcare if access bars were lowered. Maybe a little surprise there. Next slide. Again, this shows kind of a preponderance toward wanting change. At the top half or a third, where you see high percentages, those essentially are pro-change. The bottom low percentages are anti-change. And I know I'm painting with a broad brush, but to save time. So for instance, to say that government is always inefficient and wasteful, a decent sized minority, but it's the minority of our respondents that felt that. And a tiny minority felt that we're doing better than any of the alternative options. Next slide, please. Some of the statistics we were able to do, thanks to Dr. Cunningham, were to say, well, if you think that, does it correlate with that? And so here are the top correlates of feeling of expressing support for universal health insurance. Eliminating pre-authorizations, #1 correlate. #2, if it meant that we could have freedom to go and wherever we want, choose your own provider. #3, if it compensated for social determinants of health. I believe strongly in the need for that, but to tell you the truth, I was surprised there were that many respondents that was a strong correlate with wanting universal health insurance. I'm positively surprised. Next slide. Now, correlates of a lack of support for universal health insurance. These were the top ones. No competition and losing autonomy, Dr. Catsfield, who you've just said, not a lot of evidence for that, but there's a strong feeling that goes with not wanting to have universal insurance. Loss of income, which you also went over as probably not from your talk, but there's a strong feeling. And again, a concern that too many people would burden the system and it might collapse under the weight if the bar to get over to get access was lowered. If it got easier to access healthcare, the system might collapse under the weight of demand. Next slide, please. Well, what next? I hope there's some time for question and answer. We're going to send the survey link out to everybody. There's no need to take it a second time, but if you haven't done so, please do. And by the way, we'll be able to tell and separate who took before versus after. We want to know who you were, but some might think that we get confused by differences in response if this session changed any thoughts. We will do our best to find a way to get really comprehensive survey results eventually available to the attendees of this meeting. And I finished 1 minute early, everybody. I want thumbs up. And thank you very much for your time.
Thank you, Dr. Pierce, for the presentation of some incredibly important results. And I look forward to seeing what questions people might have for you when we get to the Q&A.
Thank you, so do I.
Our next speaker is Dr. Mike Flynn, who I will say on a personal note is one of the first physicians I met during my medical school and experience, and did a rotation with him. I did actually an internship with him over the summer before my clinical years. He is an emeritus professor in the Department of Surgery at the University of Louisville. He practiced in Louisville for 15 years. He has advanced senior fellowship in head and neck surgery, and he is also a Navy veteran. Welcome, Dr. Flynn.
Well, thank you, Susan. Can you hear me all right there?
Yes.
Yes, we can.
Okay, good. Well, in this section, we'll deal with where some of the money that Gene Shively was talking about that's being wasted might go. This is private equity in U.S. healthcare, where the wolves of Wall Street intend to profit from patient care. Next slide, please. So let me begin with a fundamental question. What is healthcare? Is healthcare a commodity like the gas you put in your car or the groceries you buy at Kroger's, which allow a for-profit company to make money for investors? Or is this an essential public service and a government responsibility, which we've actually just heard about very well? Next, please. So in this country, healthcare is an industry focused on allowing an assortment of entities to extract profit from healthcare activities. In most other first world countries, healthcare is a system focused on providing healthcare to their citizens. Next. So this is an incomplete list of other first world countries that have all figured out ways to provide healthcare to their citizens, usually as part of some government-run system. The Scandinavian countries, the European Union, Canada, we've heard about that quite a bit so far, Australia, New Zealand, countries very similar to this country, Singapore, Japan, South Korea, Taiwan, Saudi Arabia, not exactly an example of raging socialism, and Israel. Next. So just to give you a few examples of how these countries have found different but similar ways to provide health care for all of their systems, their citizens. 1948, the National Health Service was established in Britain. This is funded by general taxation, and it runs everything. It does the hospitals, physician offices, the pharmacies, and private insurance is available if you choose. 1984, both Canada and Australia both established some government-run health insurance systems that are similar but different. In Canada, it covers doctors and hospital costs, and private insurance or some employer program is needed for drugs, dentistry, hearing. Australia, 1984, universal health care, multiple source funding, and a private health insurance is also available if you choose. Australia has a Department of Rural Health, something Dr. Koenig mentioned earlier might be helpful to people in rural America who are running out of healthcare. Japan went through a 10-year transition to establish universal coverage in 1961, multiple funding sources, no for-profit hospitals, insurance, health insurance is mandatory, healthcare fees are regulated. South Korea, 1989, again, universal national health insurance, a lot of funding sources. They levy a surcharge of 6% on tobacco to partly cover the cost of this. And then finally, we have Israel, universal health care, medical insurance, compulsory, and you can increase the coverage if you'd like with private health insurance. Most of these countries provide government-run insurance. Next, please. So let's talk about private equity. These are professional investors that raise large amounts of money, usually from other affluent investors. This is reinvested in a wide range of ways, seeking the biggest possible profit. Now, this is good business, no question, good business. Next. Now, when private equity gets into healthcare, there is this fundamental conflict of interest between profit and patient care. So private equity firms have purchased an assortment of health facilities, nursing homes, hospitals, physician practices, surgery centers. They buy the non-professional component and, quote, improve efficiency, unquote. They expect to get a return on investment of 15 to 30% a year, and then sell it for a profit in 3 to 5 years. And this is not meant to be a long, happy marriage. It's good business. Improving efficiency in a nursing home involves decreasing the staff and increasing medication, so the patients either lay around in bed or in their chairs, don't demand a lot of care. In a physician practice, it encourages profit-enhancing activities, profitable procedures, upcoding, and referral to physician-owned businesses. Next. Now, two examples of the kinds of situations that you can get into with private equity-owned medical facilities. As was mentioned earlier, 70% of nursing homes in this country are owned by private equity companies. There are an abundance of horror stories of patients left on toilets and lying in bed with unchanged diapers. nursing home in Florida, references below on the slide. Patient died of a fecal contaminated decubitus ulcer. Unhappy family hired a lawyer to determine some degree of accountability and ran into a nightmare corporate structure. One company owned the building, another company had a license to run the nursing home, another company the professional staff, and another company the custodial staff. I mean, this is good business, bad patient care, and the company and the family really could not determine any degree of accountability with this process. Next. Another example, a large dermatology practice in California learned a lesson in corporate governance. Private equity company bought the non-clinical assets. They established daily and monthly financial goals and provided financial rewards when these goals were met. They encouraged revenue enhancing procedures, Botox, laser, Mohs surgery, encouraged referral to company-owned labs and pathologists. Management at one point made a decision to order cheaper brand of sutures and needles without consulting the medical component. And again, good business decision. It lowers the cost of practice and then there's more profit. The quality of the needles was so poor that they literally broke off under the skin during injection. Next, please. Now, let's look at the next target of the wolves of Wall Street, Medicare, a program which in this country is probably extremely popular. These direct contracting entities were part of a Medicare pilot program toward the end of the Trump administration, and it's still hanging around in the Biden administration under a different name. Now, these are middlemen who will coordinate the Medicare beneficiaries' care. And these middlemen are commercial insurance, private equity, and Wall Street investors. Just the people you want managing your mother and grandmother's healthcare. And this is another privatization of Medicare approach. A Medicare senior can be enrolled in one of these direct contracting entities without their knowledge or consent. So how does this work? Well, the direct contracting entity will collaborate with, let's say, a primary care physician practice, and they will bundle the groups of Medicare patients together and identify the amount of money that it would cost to provide this care based on their morbidity and health status, and this information comes from the Medicare database. And then they would encourage the medical facility to provide the care for less than that amount. And in this program, then they would be allowed to keep as much as 40% of the money not spent on care as profit. And then this would be shared between the direct contracting entity and the practice or the surgical center or whatever health facility in whatever deal that they worked out. And some of the ways of increasing their profit are upcoding, where you upcode diabetes, pre-diabetes to diabetes, and control hypertension as malignant hypertension. Next.
Mike, this is such great information, but I just wanted to give you a heads up. We're over time and we still have 2 more speakers to go.
All right, I'll be very quick. The private equity and direct contracting entities' involvement in healthcare will result in the loss of hundreds of billions of patient care dollars as profited administrative waste. Next, my last slide. And the end result of this is the exploitation of citizens seeking high quality healthcare, especially the most vulnerable, the seniors and nursing home residents. Thank you for your attention and sorry for the time, Susan.
Well, I know it's incredibly hard, and the information you gave was such important information that a lot of people really don't know about. So thank you for your passion and all of your great information. Our next speaker is Kay Tillow. She's chair of the Kentuckians for Single Payer Healthcare and coordinator of the All Unions Committee for Single Payer Healthcare. She's the 2006 recipient of the Dr. Quentin Young Health Activist Award, and she is here to help clear up confusion between what is known as Medicare for All and the public option. Welcome, Kay, and thank you so much for being here.
Thank you, Dr. Bornstein. I'm really pleased to be with you tonight and to be a part of this very interesting session. My topic is to compare and contrast the Medicare for All proposal to a proposed public option. Next, please. What is the public option? The public option was actually initially a part of the Affordable Care Act in 2010, but it was removed before the passage. But it is a proposal that there be a public option to purchase that would exist alongside the private entities. It is not, would not cover everyone, and people would buy into it. So it would probably be sold on the exchanges as much as the current plans are. Next, please. The Medicare for All I have used as my North Star, the Physicians for a National Health Program proposal, which was first published in the late 80s and recently republished. It was published in 2003 in JAMA. It is a universal plan. It's publicly funded, comprehensive. It provides that everyone has their choice of physician, hospital, nursing home, rehab facility. It does away with all of that network interference. It has cost control for sustainability. It uses a global budgeting system for hospitals. It is free at the point of care, removing the barriers to preventive care, all of the copays and deductibles, and it's guaranteed. Next, please. How does the public option compare? Well, the Medicare for All, which is also known as single payer, national single payer healthcare, would be universal. The public option, no, it just is another plan that exists alongside the other privately sold plans. Medicare for All would be comprehensive. Public option, not likely, because it has to compete with the others. There is no choice of doctor under the public option. They would maintain probably those strictures that we have on the current private plans. And their cost control does not function for the public option. It is not free at the point of care. It would have deductibles and co-pays and co-insurance and all of those barriers, and the public option would not be guaranteed. Next. This is just a little more detail of the comparison. Automatic coverage would be under the Medicare for All. In the public option, you have to purchase it. It would be comprehensive coverage, including hearing, vision, dental, prescriptions, and long-term care under Medicare for All. That wouldn't happen because the public option would have to compete with the private plans. The free choice of physician and hospitals under Medicare for All, that would be unlikely under the public option because they too would have to compete with the private plans. The cost control under Medicare for All, some studies estimate we would save $600 billion a year. That savings would not be there for the public option because they would maintain the private insurance bureaucracy that takes up to 30% of our healthcare spending. Medicare for All would be free at the point of care. The public option would continue premiums, copays, deductibles, and co-insurance. Medicare for All would be guaranteed lifetime enrollment, not connected to purchase and not connected to employment. That's not so for the public option. It would still be means tested like the current private plans with premiums and government subsidies. Next, please. So there's no consensus within our country on the public option, and it hasn't been tried. Proponents of the public option argue that it would provide competition, and that competition would set up a free market mechanism that would bring down the cost and insure more people. Skeptics say no, that that's not going to happen, that healthier individuals will go into the public plan, into the private plans, and the sicker will go into the public plan, and we will result in a death spiral, meaning that the public option wouldn't work as it's proposed to do. Next. And so two of the founders of Physicians for a National Health Program, Dr. Steffi Woolhandler and Dr. David Himmelstein, have said that they believe that the public option would fail because it would function in much the same way our Medicare Advantage does, with commercial insurers pushing the sicker and costlier patients into the public plan and policymakers favoring the insurance industry at every turn. So they believe that the public option is not a real solution. Thank you.
Thank you, Kay, for a superb presentation. I want to comment that I am aware that we are running behind schedule. We only have one more presentation left, and I'm certainly happy to stay on for a few minutes and invite the panelists to stay on for a couple of minutes to answer any questions that you might have. Our next speaker is Mark Shore, who's a solo private practitioner in Newport, Kentucky. He's a graduate of the University of Louisville School of Medicine and residency in Cincinnati. He's a past faculty member at the University of Cincinnati. He's worked in the county jail, the Indian Reservation, and in Cambridge, England. He's currently on the board of the KBML and the Northern Kentucky Health Department. And his presentation is being given with assistance from Alex Taber, who couldn't come tonight because he's a first-year internal medicine resident at the University of Kentucky and is on call tonight. Alex is currently serving as the president of the resident and fellow section of the KMA. So welcome, Mark. Welcome, Dr. Shore. We're thrilled to have you.
Thank you. Good evening. I'm Dr. Mark Shore, and as Susan said, I practice general internal medicine in Newport, Kentucky. And tonight, I'd like to give you an overview of the major healthcare systems that currently operate throughout the world. Now, just think of this as a primer of healthcare delivery systems that are different from our own here in the United States. Next slide. Any healthcare system has four fundamental questions it must answer at the outset. Will there be coverage for all or not? How will providers and hospitals get paid? That is, who ultimately signs the check? The revenue stream. Where does the money come from? Will this simply be a tax? Will patients and employers pay together for some sort of insurance? Or does the individual pay the provider directly? Finally, who does the physician work for? Does he or she work for the government, the insurance company, a big group practice, or for themselves alone? Now, there are four different models that I will present tonight. The Bismarck model, which originated in Germany, the Beveridge model from the United Kingdom, the National Health Insurance model, Canada, and lastly, the out-of-pocket model, which is in use in some African, South American, and South Asian countries. Next slide. The Bismarck model is named after Otto von Bismarck, who established the world's first national healthcare system through the sickness insurance law of 1883. Everyone is required to belong to a sickness fund or Krankenkassen. Insurance plans are required to accept all patients and pay claims submitted by a recognized doctor or hospital. Elected government officials negotiate terms of medical care. Well, this can vary from region to region. Now, premiums, they're paid jointly by employers and workers, that is the patient. The patient pays a premium to a private insurance fund through payroll taxes based on a percentage of income. The employer also pays part of the premium. At that point, the patient is done. They never see a bill. The doctors and hospitals are paid directly from one of the hundreds of insurance funds that the patient can choose from. Reimbursement to the provider is already established. The key is the private insurance funds are non-profit entities. Profits are used to pay for medical bills, not to pay dividends to shareholders. A few things to note. As the premium for the patient is based on percentage of income, the premium stays the same, no matter what insurance fund he or she chooses. The insurance funds are required by law to offer a mandated package of benefits. Finally, for the unemployed, government unemployment benefits cover the insurance premium. Next slide. And the next slide. Thank you. Now let's turn to the United Kingdom. This was designed by Lord William Beveridge and established in 1948 as the British National Health Service, or the NHS. As in the Bismarck model, everyone is covered and the patient never sees a bill. It is paid for through a network of taxes, including sales tax, known as the VAT, income, and Social Security taxes. This system is straightforward in that the government owns the hospitals, pays the doctors, buys the medicine, and covers all the bills. If you work in a hospital, you are a NHS employee. If, however, you are a general practitioner and work in an outpatient setting, you are not employed by the NHS. The GPs are independent businesses that run their own practices. There is, however, only one payer, the NHS. One thing to make special note of, the GPs are empowered to be the gatekeeper of the system in an effort to keep costs down. Next slide. Now let's look north to Canada. They have a national health insurance plan. This is a publicly funded system called Canadian Medicare. That's right, Medicare. Sound familiar? This is something of a mix of the Bismarck and Beveridge models. As with the other two, everyone has health insurance. Canadian Medicare is a taxpayer-funded medical insurance program. But while the Canadian government sets the rules and provides much of the funding, Canada's 10 provinces and 3 territories are the payers and operates its own Medicare plan. There are minor variations to each plan, but each one is a public entity, must provide medically necessary services, and everyone must have access to care. Canadians are also permitted to buy private insurance, and 2/3 do. They pay for items that are not covered by Medicare, such as private hospital rooms, dental care, and prescriptions. Next slide. Well, the out-of-pocket model. What does one do if there is no insurance plan, either private or public? The patient pays for everything. In that case, one pays the best he or she can or goes without. And many in poor developing countries go without medical care. As you can imagine, the life expectancy of these countries are some of the lowest in the world. Patients do try to pay or barter for care if it is even available in their area. The government or public care that is available is often centered in major cities, so only a small percentage of the population has access to care. Next slide. What about us, the United States? Some may be surprised to learn that we have here in the United States health systems similar to the ones discussed. The VA system is similar to the Beveridge model. It's government run and operated with government employees in government facilities. US Medicare is arguably similar to the Bismarck plan with federal oversight, but with multiple private insurance plans. And yes, we still have a substantial number of citizens who pay solely out of pocket for healthcare. The next slide. Whatever system a country has, it would be ideal if everyone had access to basic medical care. Some countries do better with timeliness of care, while others, like Canada, will make you wait. And some countries, like the UK, will not offer a treatment you may want. Finally, how much will this cost? And what is each society willing to spend? Next slide. Whatever we decide as Americans on how to deliver and pay for healthcare, one thing is for certain: we can do better. No matter how one measures it or what one measures, we can do better. We can improve our infant mortality rates, our quality life years, and our health information technology systems. We must remember we spend more money per GDP on healthcare than any other country in the world. Next slide. Here is just one example. We have more neonatal specialists and NICU beds, but our infant mortality rate remains high. Next slide. In closing, the basic question we need to ask ourselves is, what do we want in our healthcare system? How will we balance the different values that we all have in a heterogeneous society? Do we all believe in some sort of guaranteed issue where everyone has the right to obtain a health insurance? Do we believe in the individual mandate, meaning we should all buy some sort of insurance so that others will not do without? Perhaps taking a critical look at the above models will help us find an answer. The next slide. But no matter how we look at it or what we decide, access, cost, and quality are all interrelated. If we can have a positive impact on one, we will all be healthier. Thank you. I would like to thank Alex Taber, who did prepare the slide and organize the talk. And just lastly, an excellent reference for this is a book called The Healing of America by T.R. Reid. Thank you and good night.
Thank you so much, Dr. Shore and Dr. Taber. And Dr. Shore, if you'll send that reference on to Monica, she's going to send out, I'm sorry, Monica Miranda. She is going to send out a list of references to the group. I am thrilled to see that most of the participants have stayed with us, and I would like to open it up for questions and answers because I know that this has been a tremendous amount of information and it's getting late. John Bingham had a question for Dr. Cooper. I'm not sure if he can see it in the chat, but he wants to know if you can envision any policy levers which might push the rest of the world towards paying their weight with regards to medical innovation.
That's a strong question. Again, in the United States, the system does differ and is weighted toward innovation. I do believe in capitalism. Capitalism is less popular than it used to be, but when there's a chance for the profit motive to be there, then you're going to have people that are inspired to come up with new and different types of medications and technologies that are going to benefit our patients. And that's why I argue for maintenance of that incentive in our healthcare system. And I hate to see it go away, which I think it would if we went to a totally government-run system.
Dr. Bornstein, I don't see any other questions currently in the chat or in the Q&A.
I've got a question for Kay or a comment.
Yes, sir, Dr. Flynn, go ahead.
Kay, when I talk about Medicare for all with non-medical people and even some of my colleagues, they don't totally understand that this is just an insurance system, that this is not a system like the United Kingdom where they run the entire healthcare system. I'm just kind of curious whether you run into that same kind of experience in your spreading the word activities in Kentuckians for single payer.
I have heard it, but it's not the most prevalent question that people ask. Most people ask about what would the cost be and what would it do, and there is some concern that people might lose something that they have. But most people are eager to have a change because we are now in a crisis time with, medical debt rising so high and great dissatisfaction among physicians. And the problem is this whole new value-based payment industry that Dr. Neal talked about. I think people are ready to go for a reform that would work. And there is majority opinion for our Medicare for All system.
Mike, there is a question for you. What do you see as one of the most essential steps to trying to break down those for-profit systems in place to create universal health care?
Well, Well, this is, as we all know, this is political. And I mean, I joined Kentuckians for Single Payer a couple of years ago because I think it's the right way to go. Unfortunately, in the political state that we are in this country, I don't see anything happening anytime soon. I mean, I am hopeful that there'll be an awareness in different parts of this country, especially in rural America, about the benefits of a single payer system, but I don't see it happen anytime soon. And I've talked with Kay and some of the other folks in Kentuckians for Single Payer about this, and unfortunately, that's just the reality that I see. I'd be curious to hear what other folks' thoughts are about that. The silence of the lambs.
Well, maybe we can come back to that. I wanted to get to a question that Dr. James posed for Dr. Shore. He commented that Dr. Shore mentioned access. How would the systems deal with equity?
Well, I think the main point there would be that you'd have the individual mandate where everyone would pay into the system and everyone could have access to care. And I think it would be equitable. Most of these systems mandate or a basic package of medical services that must be provided. So I think that would be equitable. I believe I answered the question.
Thank you.
Dr. Cooper, you had your hand raised. Did you have a question or a comment?
Yeah, I wanted to make one comment and would be interested to hear response from Dr. Casfield and Dr. Flynn. As we get into these discussions, we're always comparing ourselves to other countries, and that always causes some concern for me. The United States is 330 million people, and Canada is 37 million people. California is 39 million plus people. So sometimes we get into these discussions as if it's the same playing field, and it's really not. In addition to the greater population of the United States, there's a lot of diversity from state to state. So I don't think the arguments always translate that well, comparing ourselves to other countries.
If I may comment on that, one thing I learned in researching this, everyone seems to be talking about necessarily a federal system. The Canadian system started just in the province of Saskatchewan. So it doesn't necessarily mean that everything has to be centrally located. When I was a resident at the University of Cincinnati, the Hamilton County of Ohio, which the city of Cincinnati is in, they passed a levy each year to help pay for indigent care. So these systems could start small and be regional. And in that way, it could even be more manageable. And I think take away this fear of Big Brother.
Well, let me make a comment about that as well. First of all, I agree that this country is different than Norway or Switzerland. And you're absolutely right about that. But at the same time, we have, in addition to the VA, I spent 20 years in the Navy, the Naval Medical Corps. And there are more medical officers in the Naval Medical Corps than there are medical service corps officers who are administrators, because the purpose of the Naval Medical Corps and the Air Force and the Army, I think, is the same, is to provide medical care. Someone mentioned this earlier. We have had an over 3,000% increase in the administrators, the managers, the bean counters in healthcare in this country between the mid-1970s and the 2010s, so that there are 10 of them to every practicing physician. And the reason for that is the focus of this system is not providing care. It is an industry that is focused on extracting profit from an assortment of healthcare activities. And until we get past that, it isn't going to change. And I agree with you that capitalism is a good system when it comes to cars, clothing, agriculture, whatever you want. But when you put capitalism to work in healthcare, it's good business and bad patient care.
And I would agree with that, there were doomsday scenarios about signing people up for Medicare, and I forgot the exact number of people who were signed up in months. It was in a short time because people said, how can we sign up all of these people back in 1965? And it was done very rapidly. And I also think that we are a very different country from all of these other countries, which are different from each other, but there's nothing in that difference that I would say prohibits us from going to a different financing system. And it could be done regionally and very sensitively to the needs of each region.
The only thing that's going to prevent us from doing that are the politicians.
Mhm. Maybe we could start with California. That might be a good idea.
They tried.
One of the things that I like to think about from a framing standpoint is I think that Dr. Cooper is right, that there is excellent medical care for the President of the United States. If you'll remember, when Mr. Trump got COVID, he got access to health care that was not available to almost all Americans. And so I think that one of the questions that we need to ask ourselves is, do we want to have or perpetuate or believe in a system that has really amazing healthcare for the percentage of people that have both the economic ability and educational ability to be able to navigate that system and advocate for themselves to get the very best of the care that's available? Or do we want to be, while leaving many, many people unable to get any care whatsoever? Or do we want to be a country that says that healthcare is a human right and that you should be able to get healthcare even if you don't completely have, 5 advanced degrees and a hotline to the chief of radiology? I have a friend who is a very strong market person, and yet he has has very high social standings in the community and is able to get the head of radiology on speed dial whenever he needs something urgently. So yeah, it's great healthcare for him, but it's not so much great healthcare for the janitor in the West End who doesn't have health insurance. So just some thoughts.
I'm not sure that's valid, Susan. We've taken care of a lot of COVID patients here at Harrison Memorial Hospital. Some of them were insured, some of them were not, varying degrees of coverage, and all of them got the same standard of care for their COVID problem. I can promise you that. So I think your argument actually comes more into play when you look at preventative care and access to preventative care. That's where I think the system breaks down more. People who need urgent and emergent and advanced care, anybody can get that in most any hospital in the United States. But accessing preventative care to keep you from getting into that emergent situation, that's a different story.
Now, it was mentioned earlier in one of the talks, I don't remember who it was, about bankruptcy. 60% of bankruptcy filing in this country is related to medical costs. The cost of medicine, not the loss of work, but the actual cost of medicine. There are between 200 and 800,000 patients a year who file, depending upon the year. There are millions of people in this country who have medical debt, not necessarily medical bankruptcy, And there was an article that I had in a paper that I'd written that in France in 2017, there was one. I have one index finger sticking up here, medical bankruptcy in that country. So, you know, when you've got a CEO of Cigna or Anthem making $30 million a year, when the nonprofit Blue Cross and Blue Shield were paying them $500,000 a year, and the CEO is just the top of the food chain, and you go all the way down, the next guy's making 25. It's insane. And until some of that penetrates the brains of the politicians and some of the people who live in rural America, nothing's going to happen. I mean, it drives me nuts. I don't know what else to say about it.
There was also data in New York, and I can't remember the exact figures, somebody else might know them, but in the early stages of the pandemic, before they made COVID treatment free, many people died of COVID because they did not feel that they could afford to go to the emergency room because of the risk of incurring the debt that Dr. Flynn talked about. So yes, they technically have access to the emergency room, but they perhaps did not want to put their families in the precarious financial situation that would be entailed by accessing that care.
And I would like to, as someone who took care of a large percentage of people who are uninsured prior to the ACA, I would like to echo that yes, if you come to the emergency room, you can get that care, but many of those people I could tell you tons and tons of stories of people who opted not to get advanced care for cancer, et cetera, because they said they couldn't afford it and they would be afraid they would lose their homes, et cetera. So, I think Susan's point about it's wonderful care for the people who can afford it and who are smart enough or educated enough to access it. But there's a whole bunch of people that don't have those opportunities. And like I said, I could tell you stories that would break your heart of people who died unnecessarily because they were afraid to come in and get treatment because of costs. So
I'd like to bring up something a little different, and I don't mean to start a 10-minute conversation, but it might. Dr. Neal and Dr. Koenig, maybe others touched on the fact that we have physician shortages geographically, for sure, and sometimes even broadly beyond just geographic distribution. And if we're going to look for change, and to that minority on our survey who are worried about the system collapsing under the weight of greater access, there's going to need to be, in my opinion, some way to increase our physician workforce. And probably there's going to need to be some way to bring down student debt as part of that. So that's a statement, not a question. If there is a question at the end of this, has anyone read or have knowledge of the countries that do better than us in terms of what they do to make their physician supply better match their population? I'm hearing crickets, but it's a problem I think would need to be solved.
it is a problem, and the funding for sort of the bottleneck is the residency positions, and the funding for the residency positions have been tied to Medicare traditionally and have not increased significantly since, I don't know, 1980 or even before then. I can't remember the time. I actually was a lobbyist in DC trying to work on increasing the funding for residency slots. They have increased the medical school numbers, the number of kids going to med school, and the cost to medical school is something else that needs to be addressed. When I was going through medical school, I graduated in 1982. The state subsidized a significant portion of my medical school education. And over time, they have stopped doing that so that the students are the ones that are left having to really pay for that. So that needs to be addressed. But also the real issue is that medical schools can increase in size, and they've also increased in number, but they have not significantly increased the residency slots. So you can't practice medicine here without a residency. I would like to make one comment. I just got a notification from NPR It said medical debt affects more than 100 million people in the US, forcing some to lose their homes and savings. So just got that hot off the presses. It came across my feed. So.
And one of the things that I would say is we have an upside down workforce pyramid. So my understanding, and don't quote me on it, is that, you know, if you want more primary care doctors than specialists, then you offer more primary care residency spots and less specialist spots, so that the people that come out of medical school will be funneled into the careers that you need, that the country needs. We do have one more question that's popped up in the chat, and the question is pertaining to whether or not we shouldn't focus on what the individual can do to be healthier, since obesity and diabetes have increased because of individual decisions and not because of any medical delivery systems. And so how do we want to address individual behavior in this discussion?
Well, one way would be better financing that would improve social determinants of health. And I don't personally think, as a physician, I have the expertise or the bandwidth, or maybe even the interest, to be the expert who's going to help people really follow healthier lifestyles. I try really hard as a family physician to do that, but I need a lot more than just me. There's the environment, there's social work, there's mental health, all around that. And countries who do better spend more money on those things, not necessarily through medical care, but they spend more money on supporting people who essentially become chronically ill through choices that could be prevented and not encouraged. For instance, you know, I know everybody a lot of people think this is a horrible idea, but if we're going to tax cigarettes and tobacco, how come we're not taxing super high calorie food and using that money to pay for social determinant of health support?
And on that note, I think we should go ahead and wrap things up, since we're already 20 minutes over. But I'm glad that we had the opportunity to have a discussion, a very respectful discussion. I really appreciate all of the differing points of view. And thank you for those of you who asked questions and allowed it to spark additional discussion. I do want to remind everybody to please fill out the evaluations, and we are hoping that we will be able to make slides and recordings available to you, but we need to coordinate with the panelists and with Miranda on that. So we will get back, hopefully we'll be sending out information about that. Thank you so much. Really appreciate everybody's being here.